Good afternoon, everybody, and thank you for joining the webinar today. Today we are going to talk about overcoming challenges for your early mobility program. And just a quick introduction, my name is Margaret Arnold, and I am the CEO of earlymobility.com. My background is in physical therapy. I've also run safe patient handling programs and early mobility programs and help consulting around the country and some international consulting to help people with their early mobility programs. So I'm excited to share with you today some of the tips that we have been able to help people with to overcome many of the challenges and barriers that they run up against with early mobility programs. What is your greatest barrier to implementing early mobility? Resources, staffing, time, money, absolutely. COVID, that one comes up again and again. And these are real issues, they are real challenges. And what we're going to talk about today is no matter what the barrier is, no matter what the challenge is, what are some strategies that we can provide or implement to help overcome some of those barriers that we see? Another one that I frequently hear is leadership, that we can't get our leadership to buy into the program. So, what are some ways that we can get buy-in from leadership? How can we establish the big why? How can we define the problem? How can we create enthusiasm and vision for the program? How can we align with facility strategic initiatives? Set expectations, prioritize safety. Again, this is a big challenge for all hospitals, not just to implement their programs, but also for sustaining a new program, even if they've been able to implement it. We need to build community and engagement. We need to build trust and really spread the benefits of early mobility and the ownership of the program across multiple stakeholders in the organization, not just one or two champions who are trying to make a difference. And then we need to be persistent. This is probably one of the biggest factors for any program, but in healthcare especially. We have to be persistent even in the face of barriers, challenges, roadblocks along the way. So, safe early mobility is caring in action. It's through a culture of safety that we achieve safety for both patients and those caring for them. It is the right thing to do and contributes to excellent patient care. Now, this particular way of describing safe early mobility utilizes a mission statement from a certain facility. And all healthcare facilities, all systems have a mission statement and a vision statement. And if you in your facility can pull that vision statement, that mission statement up and use the words from your own facility, because almost all of them, if not all, have quality of care, best outcomes, great value. We care for our patients. We are driving towards excellence. We want to achieve zero harm. It's the right thing to do. These are commonly found in healthcare facility mission statements. So let's use that language, because safe patient handling, early mobility is part of how we accomplish that. There's another way we can get people's attention, and we can say immobility syndrome is a killer, because it absolutely is. We are not exaggerating. Hospitalized older adults with low physical mobility, such as ambulation, are 34 times more likely to die and 6 times more likely to be institutionalized compared with those who ambulate 2 or more times a day. This is an article written by SMART in 2018 in a scoping review in the Gerontology Geriatric Medicine Journal. Now, it's not just in the hospital. We know that the impact of immobility across all care environments, in the home, in the community, in long-term care, skilled nursing, even in acute rehab, we are under mobilizing. And so these numbers are startling, but they are real. Immobility syndrome also harms patients. So when we are trying to get to zero harm, know these facts, learn these numbers, know your resources, because this is how we can get the attention of our senior leaders. The American Geriatric Society wrote a paper in 2018, Implementation of Mobility Interventions Prevents Falls, it prevents deconditioning, it improves cognition. Up to 68% of patients admitted to acute hospitals are discharged with some level of disability related to muscular deconditioning. So not related to the condition that they came to the hospital for, but because of the immobility and the deconditioning that they acquired during their hospitalization. And then according to the Merck Manual in 2019, 75% of patients 75 years and older, functionally independent at admission, are not at discharge. And 15% of them are discharged to skilled nursing who were independent at home before they came to hospital. These numbers are startling. But if the numbers themselves don't speak to certain individuals and get the needle moved, because remember, all of these actions are designed to get buy-in and support so that we can move forward. Not just lip service, yes, Margaret, that's a great idea, but how can we move this program forward and actually achieve a program that is working and is sustainable? So I'm going to share a couple of videos now from survivors of immobility. And again, sometimes these patient stories can get to the heart where perhaps data or numbers don't. So let's just play and hear what these patients have to say.
I could hardly lift my limbs off the bed. I could not sit up. I couldn't walk. I couldn't stand. I remember the first time he said, it'll be several months in rehab. And I was like, but this is pneumonia. And it really wasn't the illness that she was recovering from. It was the immobilization that she was now needing to recover from. The reality of how little she was able to do was a real surprise.
So these are real people, real problems.
You're out and you don't know how you got there, and you know it's a trip you went on you didn't know you were going on, and now you're awake and everybody seems to be all excited about it, and you don't know why. Time is gone and you can't figure it out. The emotional part is you see life is different. You're scared of getting sick. I don't know the rest. I don't know why I feel sad and unhappy. I don't know why. I thought it would get better.
So these real patient testimonials, and I want to thank the team at Vanderbilt University who have a website with even more testimonials and videos on there. But this is real, and these are people's lives. So we have the opportunity here to really and tangibly change the outcome for these patients when they come to our hospitals. Now, maybe the numbers that we shared, maybe the videos have not moved certain individuals to action in our facility. There is a huge amount of evidence. And this is another way to get our leadership, our physicians, our providers on board to say this is evidence-based practice. Our nurse leadership, we are driven to provide evidence-based care. And immobility syndrome is against what best evidence is. So a couple of articles that I wanted to share with you here, these are systematic reviews, which is the highest level of evidence. And this was a study that was published in 2019, so just last year, 23 randomized controlled trials, and found that patients who had received early mobility were 60% less likely to have ICU-acquired weakness at discharge. That means those patients can still get out of a chair by themselves. They can get up to the bathroom by themselves. They can go home. Whereas when they cannot get out of a chair, now they either have to be institutionalized or somebody has to care for them at home. They are no longer independent. They were more likely to be able to stand, they had more ventilator-free days, they walked further unassisted, and they were more likely to be discharged home. Another article in the Critical Care Medicine in 2019, over 15,000 patients at 68 ICUs. So this is a large study done by the team at Vanderbilt University, found that when all elements of the A, B, C, D, E, F bundles, those patients had decreased risk of hospital death, decreased likelihood of next day mechanical ventilation, they were less likely to be in a coma, less delirium, reduced physical restraints, less likely to be readmitted. These are important initiatives in all health systems across not just America, but across the world. So early mobility can absolutely make a difference, and the evidence behind it is really strong. I'm not going to go through all of these slides. I just wanted to include them in the slide deck as resources for you when you approach your senior leadership, to show just how many articles there are that are relevant to these strategic initiatives that we're already trying to address in healthcare. Suicide risk, length of stay. This is huge, especially in our COVID times where we're reaching capacity in our ICUs and in our hospitals. We have to try to get these patients out of the hospital, but better and functionally able to go home. Because the other thing, especially with COVID, is a vulnerability in our long-term care and our nursing homes. So if our patients are coming to us with COVID, we certainly want to make sure they can go back to their homes and not have to worry about going to a nursing home, either taking COVID there or being vulnerable to acquiring COVID if they do not have it when they're left. Falls are another huge initiative. Lots of articles that show the impact of early mobility on falls, and then also catheter-associated urinary tract infections. By getting up frequently, we retain an individual's ability to go to the bathroom. Now, that's not just about preventing UTIs, it's about the very dignity of a person's privacy and their ability to control their own personal bodily functions. Ventilator-associated events are impacted. Pressure injuries are positively impacted. And I'm going to go into a little bit of the dollars and cents now, because if the numbers don't get attention, let's talk about the economics of early mobility. The incidence of falls are 1.7 to 25 per 1,000 patient days. Average added cost of care for every single fall is, according to AHRQ, about $6,600. And the average length of stay goes up by 6 to 12 days. This is all falls. And according to Medicare and Medicaid, $30,000 is the added cost of care if there was an injury. Whether that's a lawsuit, whether it's an additional surgery, whether it's additional consults, x-rays, and additional care for that patient. Now, what's the impact of early mobility on falls? Reduces falls by over 50% in an average of about 6 different articles. So again, this is not just random numbers. This is strong evidence-based practice that these are impacts that can be measured right away with early mobility programs. What about the cost of a length of stay? According to Khan, which is the most conservative dollar amounts I've seen on any economic analysis, for the cost savings on a reduction in length of stay, what we believe that to be is around $249 a day. Now, that doesn't seem very much when you look at the average cost of an ICU day being anywhere from $3,000 to $10,000. But we have to be realistic. When we reduce length of stay, we don't reduce it off of the front end. We reduce it off the back end. Much of the expenses are incurred up front. Getting the ventilator, the bed costs, the consults, the different specialized tests. If we shave half of a day off at the tail end, we're not going to make as much of a difference. However, even at $249 per patient, by reducing 1 day in length of stay. If you have 1,000 patients admitted to your ICU a year, you're looking at almost $250,000 just in length of stay alone, even without falls, pressure injuries, etc. Now, the average length of stay reduction with early mobility is between 20 and 30%. That is significant, and it's over multiple different facilities, multi-system randomized controlled trials, and in multiple countries. We also can look at pressure injury costs. One pressure injury, stage 3 or 4, adds $40,000 to the cost of care. Now, that may not seem that much in the context of a $5 million budget, but once you start adding all these numbers up, you can show that the economics of your early mobility program far outweigh the cost of implementing that program. And wherever you can get your leaders' attention, whether it's through the right thing to do, whether it's the patient's testimonials, the research, the numbers, or the dollars, know these numbers and have them in your pocket when you're speaking to leadership. If you don't know them, you can take this PowerPoint presentation. It will be available to everybody after the webinar today, and use the numbers to help you overcome this barrier. Pressure injuries, again, are reduced by up to 40% with early mobility programs. So the other way to overcome that barrier of leadership and just getting this initiative on the table and getting a committee formed, getting some commitment from leadership to prioritize early mobility, is to align with current strategic initiatives. Use language that is already being used in your facility. Understand what the drivers are. So for example, on this slide, you'll see a high reliability graphic. Many of our healthcare systems right now are striving to get to zero harm through high reliability and an increased focus on safety. But lots of organizations, they have these initiatives and they have these strategic plans and these goals, but they lack a tangible conduit to get there. The methods and the interventions to achieve zero harm are all over the map, and they're siloed, and there's multiple different committees. For example, a fall prevention committee, because we were trying to prevent falls. Many of the fall prevention interventions actually make patients stay in bed. The bed exit alarms that beep every time a patient tries to get up, that is good for fall prevention in that moment. But when we understand that a patient who does not get up gets 3% weaker every day, and we understand that their cognitive abilities decline with every day of immobility, we have to find a better way. So early mobility done safely, as we'll talk about in a little bit, is a vehicle that can help us actually achieve that. When we look at the high reliability, visible leadership engagement is one of the key pillars. Strong commitment to safety is another key pillar. And then commitment to robust quality improvement process. Many of your organizations are already speaking this language, so you can feed into that with how your early mobility program is going to help them reach their strategic goals. And then the guiding principles, there's 5 guiding principles. Preoccupation with failure. We have to be looking for that immobility syndrome. We have to have sensitivity to operations. So we're going to try and align with other committees. We're building our community. We're building a team that is aimed at total patient safety and caregiver safety at the same time. And then we have a reluctance to oversimplify. We have to set the expectations for our programs that we're not going to get the outcomes unless we do the work. Many facilities that we've consulted with over the years want to get the outcomes. Everybody wants the outcomes, but then want to cut corners when it comes to training, cut corners when it comes to equipment. Let's cut this out of the program. Let's cut that out of the program. The challenge is when we look at reluctance to oversimplify with high reliability, you don't get the outcomes without putting in the work. And so we set those expectations up right at the beginning of the program. Be very clear with what it's going to take to get those outcomes, and then hold fast to that. Because when we allow ourselves to our safety and our programs to be chipped away by we don't have time, we don't have money, we never have time, we never have money. But look how much money we're spending anyway. We're spending the money on falls. We're spending the money on pressure injuries. We're spending the money on longer length of stay than we need to, on ventilator-associated pneumonia. We can save that money and direct it to prevention and show that we can make a difference and we're budget neutral or we're even out ahead. And then commitment to resilience. This is really important. It's one of the most difficult pieces with your early mobility program. Commit and then stick with it, even though it's hard. If it was easy, everybody would be doing it. But we have to just use whatever pieces that we need to. We've talked about some of them already, to keep chipping away, chipping away, chipping away, and just refuse to give up, because it is, without a doubt, the right thing to do. And then deference to expertise, whether that's internal expertise with your frontline staff or whether it's bringing in external consultants. Knowing who knows best to help you get there and being not afraid to use that expertise is very important. So here's an idea of scripting. And one of the things that we run up against with early mobility champions are people trying to get their programs either off the ground or they're running into a problem with their program. They need leadership support. When we have an audience with leaders, often we only have about 1 minute of their attention, that we have to grab their attention right away. And our goal is to get a meeting where we can get slightly longer at that next meeting. A mistake that many of us make, and I have made this mistake personally many times until somebody taught this to me a long time ago, is only as much as you need to share to get to that meeting, to get to the next level, because otherwise we lose our leaders. And so this is an example of a script, and you can make this your own. You can take it and put it in your own words. But if you meet your leader in an elevator or in the cafeteria or in a hallway, or you've tried to get an appointment with them and they say, yeah, I've got a minute, and they're looking at their watch. Hi, Mr. McDonald. I'm Margaret Arnold. I'm the Early Mobility Coordinator. I'm heading up the quality improvement project aimed at keeping our patients moving while they're in hospital to avoid the harms of immobility syndrome. I'm really excited to be involved in this journey to zero harm that I keep hearing about. Did you know that early mobility research shows patients are weaned off the ventilator sooner? VAPs are reduced, not to mention reduced falls, pressure injuries, mortality, length of stay. As I was reviewing the patient safety goals for our hospital, I realized that early mobility will help us achieve those goals. I need your help, though, to get the program up and running. I'm wondering if you have 15 to 20 minutes, Mr. McDonald, in the next couple of days that I can share more details about the program and some of the specifics I need help with. To which you're hoping that they say, sure, tell me more about it. And they may have time right there where they will ask you, or they may say, yeah, get with my assistant. Or if they just say yes, you follow it up with, great, I will call your executive assistant and set that up. Thank you. Don't take more of their time than you need. But what you're doing there is the bolded text. You've clearly hit a bullet point that patient harm, immobility syndrome, something you want to say, something that is going to capture their attention. And did you know, asking a question that makes them think about it and then putting it in something that you know is a top priority. Now, if falls are a top priority for your facility, hit falls. If it's mortality and length of stay, hit that. Keep it precise, keep it short, and ask for that next meeting. And then follow up with that next meeting. Now, if they say they have more time right now, be ready for that. So have your numbers, have your research, maybe take 1 or 2 of those systematic reviews, bring them with you, highlight a couple of numbers so that you've got that next level of information to share if they ask for it. And then the next step is share that this is a quality improvement project. Begin with the end in sight. Share the vision. If they ask, Share the outcomes that you have seen achieved in other early mobility programs. Share that it's evidence-based, but show them that you know that this is a process and we need to do step 1 first, which is a gap analysis. We need to establish the scope of the problem and determine where we're at. So using graphics like this can help you show that you know what it takes to get to the end result. And leaders are very familiar with this process. And then break up your rollout into manageable steps and phases. This is also helpful with your frontline staff, your middle level management, all the way up to your senior executive team. So marketing and building your team. So let's say we've got leadership on board. What are the next barriers? Getting people excited is another barrier and another place where we really want to get people excited about the program. We need to market our programs. And most healthcare facilities, they might have some posters, but we want to blast people with the information. Why is this important? Small amounts of information that we can use. This is a Did You Know series of posters that we have available through earlymobility.com. And these are designed to be in the break room. Put posters on the back of the bathroom stalls, especially the toileting one. Did you know the average adult goes to the bathroom about 6 to 8 times a day? Now, my nursing friends will tell me, as nurses, we're lucky if we get to go once or twice during a shift. They have bladders like superheroes. But think about our patients who might go to the bathroom every couple of hours, who don't have the ability to hold when they need to go. They're faced with a difficult choice. If we tell them not to get up without us, then they need to go to the bathroom. They then have the choice of waiting for the nurse and perhaps soiling the bed, or being a non-compliant patient and getting up when they were told not to be, or they try to get up anyway and they fall because they didn't realize they're hooked up to an IV, or that they're on new medicine which increases their fall risk, or some of these things that happen all the time in the hospital. By keeping people mobile, this helps avoid these problems. But these posters are the simple facts. You can hang it anywhere for people to digest little bits of information. You can rotate them so that they're new, but keep the information coming. Engaging with staff. First, we must listen. We have to understand where they are at. We've got to make the program relevant. We have to show them why it matters. The WIFM element, what's in it for me? Share how early mobility will help them do their jobs better. We are all in healthcare to help patients when they are at their most vulnerable. It's why every single one of us earns a paycheck and why we got into this business in the first place. And so we have to get to the heart. Immobility syndrome goes against everything that healthcare is about. Time now versus time later. We already talked about money, right? You'll spend the money. You'll spend it on the problems and the immobility syndrome. So let's redirect those funds to prevention. You'll spend the time. If a patient falls or is suddenly is deconditioned because they've lost 10% strength because they've been in bed for 3 days, now it might take 2 nurses to get that patient up instead of 1. That patient might now be more anxious. If they're in bed, they're going to be in more pain, so they're going to be sitting on their call bell more often. That is going to take more time from the nurses than if that patient is mobile and is able to sit up by themselves and is able to do more for themselves and reposition themselves in bed. So why do people resist change? Fear of the unknown, lack of good information or education, a fear of loss of security. There is comfort in the predictable. There is comfort in being the expert, being knowledgeable on the floor. Many of our seasoned nurses are very experienced practitioners, physicians, therapists, nurses. They're known as the experts on their unit, and there's a pride and an identity that comes with that. And so when they are expected to do something different and something they are not comfortable with, The fear of loss of that familiar, predictable identity of being the expert is real. And we have to engage with them and understand, take the time to work through those fears with them and help them become the new expert in early mobility and help them understand why they should change. Lack of resources, bad timing. Right now, COVID is making it incredibly difficult, but yet even more important to do mobility for our patients. If it's not COVID, it's going to be something else. There are always competing priorities. Our job as early mobility advocates is to really paint that picture to say why early mobility should always be a priority. It should be a concept of care, and it should be the culture of the way we do business. It should never just be a side program that we are doing in addition to the care that we're providing. Habits are hard to break. And then getting out of our comfort zone. The other thing that we see in healthcare a lot is flavor of the month programs. And we need to make sure with our early mobility program that it does not become a flavor of the month, that the implementation is systematic, is comprehensive, is across the board, that expectations are set that every employee in this facility, in this health system, is going to provide care that maximizes mobility and prevents immobility syndrome. And that is every discipline across the board. The other reason that people resist change is they may not believe the new way is either achievable or important enough to invest their energy. So what do I mean by achievable? It might be a personal expectation that I don't believe that I am capable of doing this in this way. A lot of people feel this when there's new electronic medical records brought into play, any new practice, any new program. And if staff are already fatigued, are already stressed, are already tired, it makes their reserves for new learning lower. So we need to appreciate that. And sometimes we need to go slowly and start one step at a time, but yet we need to move forward anyway. And just understand and listen. And often all people need is a chance to have their voice heard, to know that their concerns are being taken into account as you roll this forward, and that they're not just going to be bamboozled with just another new program, another new set of expected behaviors that a month from now are not going to be expected anymore. So readiness for change. We have pre-contemplation. This is somebody that I don't really even need to think about what you're going to say. There's just resistance. There's crossed arms, body language. Don't want to hear it. And then you've got people who are in contemplative stage where they recognize that there's a problem and they wish they could do something about it. But there's many reasons, many barriers, but they see the problem. The pre-contemplative, they don't even want to hear the problem. Our goal is always to move people up the steps, one step at a time. These are ways that we can overcome the barriers of resistance, the barriers of non-compliance, of employees who do not want to change. The next step is preparation. I intend to take action. Yes, I'm going to ask my manager if she'll block me off so I can attend that training event. Yes, I'd like to be involved with that. I'm going to come to the meeting. I'm going to put that into practice. Now I've moved into action. I believe it. I concur there's a problem. I've done what I need to do to overcome some of the barriers to help us get from no action to action. And then we're going to maintain what can we do to sustain and improve the behavior. So in engaging with the people who don't want to hear it, the pre-contemplative, and just even your reflection, even today as you're attending this webinar, what are you feeling? Are you frustrated that it's one more thing you have to do? And again, think about this when you go to different trainings, different meetings in your facility. because others are going to feel this way when they come to your training, and it's important to understand that. Some are going to be really excited to learn what you have to share. Some might be angry that their manager expects just one more thing from them. They may be concerned that this is going to add work to an already hectic schedule. And we need to be conscious of that and engage it and say our goal is to change the way we do things so that you're working smarter, not harder. We want to save the work of cleaning a pressure injury and dressing a pressure injury by preventing the pressure injury. We want to save the work of trying to get Mrs. Jones up with a broken hip because she fell 3 days ago and now she screams in pain and it hurts her, and she's not only the cost to her with increased pain, but the cost to the burden of care has gone up. We want to help prevent that and just shift the care rather than just adding care. I'm ready to learn. I'm excited to make a difference. I can't wait to learn a safer way. You may have people in all of these areas who you're talking to. I know I should learn this, but I'm really tired and I can't pay attention. You may have people like that in your classroom who really want to learn, but at the end of your hour, the end of your training event, they're no more able to implement what you've just taught them than they were at the beginning of it because they were super tired coming into your program. And then you've got people there that are like, this is a good class. I wonder what I'll make for dinner tonight. Or maybe there's those of you on the webinar today who are surfing the internet and you're on Facebook scrolling through while the webinar is going on. There's lots of things going on in our worlds and we're bombarded with information all the time. The key in getting focused and intentional actions is to really engage people one-on-one and get the needle to move forward. So with frontline staff, some of the other things that we can do to overcome that resistance and that barrier is help them understand that all systems are affected with immobility. You've got an ICU nurse who's very knowledgeable, but is telling you, I don't have the time. When you can break it down into physiological change for them and share with them physiologically how this is harming their patient, the very patient they are trying to help, sometimes that will overcome that barrier. Our goal today is to give you tools, to give you different strategies, different methods that some are immediate things you can use. Put posters up on the wall, speak to your managers, talk to people about it, just increase awareness about it. Did you know you can say that to everybody, anybody? We have to know that the immobility syndrome starts from day one. Many times nurses will say, we're waiting for therapy. Let's just back up a slide a moment. We're waiting for therapy to be ordered. We're going to wait for a consult. Well, that patient might have 2 or 3 days or maybe 4 or 5 days if they're admitted on a Thursday before they get that mobility. Even within 2 days, you've started to get contractures. You've started to get atrophy, not just your skeletal muscles, but also your cardiac muscle, your breathing muscles. For many of our patients that come to our hospitals, they are operating and living just above the immobility or in the dependent threshold, where 10% muscle strength or even 6 or 8% muscle strength deficit might be the difference between them being able to get out of a chair or not being able to get out of a chair. We start to get insulin resistance, hyperglycemia. We start to get dorsal atelectasis. We start to get loss of calcium in our urine within 48 hours of not being up and moving. Now, this happens in healthy people as well as in patients. And you and I can bounce back very quickly after a couple of days. But for many of our patients, we saw this in the Merck manual and the data that I shared at the beginning of the presentation. This is the difference between being able to go home and not being able to go home. And just sharing that with our co-workers, often they're not aware, or they might have known it, but they're so busy with other things they forget. So just reminding that, keeping those facts in front of people is a great way to just get people's conscious up to a point where they want to do something about it. Smaller bouts of activity done frequently throughout the day at low to moderate intensity. So just getting up and taking a few steps to a chair, just getting up to sit at the edge of the bed, a couple of stands with a couple of steps and then back into the chair or back into bed is more beneficial than once a day. Why is that important? Because we must have all team members on board. If you're waiting for therapy to be the only ones to mobilize the patients, they've got maybe 40 minutes tops where they're moving, and then they've got 23 hours a day where they're not doing anything. So we must ensure that all team members are on board. So when we look at whose job mobility is, it's everybody's job. And let's go through some of the other barriers. As we talk to whose job is it, bring up your nurse practice standards, bring up the domains of nursing care. Because often nurses will say that's therapy's job to mobilize. Not always, but often. And there will be this perception that early mobility, when we ask nurses to mobilize their patients, that we are asking them to do somebody else's job or just adding more things to their plate. But look at all the highlighted areas here. These are all elements in the scope of nursing practice under physiological basic, activity and exercise management, elimination management, immobility management. These are core domains of nursing. And it's very helpful to share this and say, listen, guys, we are all on team patient. Let's all work together to make this happen. And then when we look at therapist practice standards, mobility is part of therapy, but it does not equal therapy. So when you have nurses who say, they're just trying to get me to do the therapist's job, that's not the case. It's what we want to accomplish with early mobility is for teams to talk to one another. And if you haven't already done this, set up a focus group with your therapists and your nurses. Maybe you start with one or two of each discipline and ask the questions and listen. Where does nurse-led mobility start and stop? And what are the criteria for a therapeutic consult? The therapist will tell you that many of them get inappropriate consults. They are consulted on patients that really should be getting up with nursing. So these are conversations that can help break down barriers and break down silos between disciplines and refocusing on patient-centered care. We are all on team patient. So this just shows that mobility is part of rehab, but they're not the same thing. We have a common goal of maximizing patient outcomes. Therapy is focused on movement and restoring function, but only with each patient, maybe 45 to 60 minutes a day. In acute care, maybe only 30 minutes. The nurses are with the patients the other 23. Frequent mobility is optimal, like we talked about already. What about the concern between mobility and falls? This is another barrier that comes up very frequently. Nurses are worried about falls, and falls are a big deal. We know this. But there's two things that I will share with you here. This article by Matthew Groden that was published in JAMA in 2017 looked at the incidence of falls and found that early mobility actually does not increase falls. But the other 6 articles that I shared with you earlier contradict that and say you actually can reduce falls. Physiologically, that makes sense. Every day in bed increases cognitive decline. We talked about that earlier. It increases weakness. It leads to gait impairment. So these are all risk factors for patient falls. We have the opportunity to do something about this in a preventive way. The other thing that we do to reduce falls is we make sure that we use safe patient handling equipment, and we're going to get into that in a moment. We want to make change easy. And I'm borrowing this from a friend of mine, Margaret Russell, who's one of our consultants with earlymobility.com, from Atomic Habits, Tiny Changes, Remarkable Results. Behavior modification should be satisfying. It should be easy. Now, getting patients up isn't necessarily easy in that moment, but if we break the steps up and we train people properly and we give them the resources and we get the right equipment for them, It is easy when we have things in place to make it easier for people. It should be attractive. They should be able to see the impact of their work, and it should be obvious. And hopefully, through the presentation today, with all the research and the patient testimonials and the numbers, it becomes very obvious that this is the right thing to do. But we don't stop there. We have to track the outcomes and get those patients' testimonies. When the patient gets up and says, "Oh my goodness, that feels so much better," don't leave that on the table. Take that and share with the rest of the staff. Look what we were able to do. Even if it's one patient, you've just made a difference for that one patient. But if you've got 5 patients that have all said, "We feel so much better getting up and out of bed," now we're impacting the patient experience. Ask your patients, would you share that with my manager when they come in? Would you share that with the doctor? Some are happy to, some are not. But let's make sure that we are taking these programs all the way to build on our early wins. So many hospitals that I work with, they do the work up front, they implement the program, but they stop short of celebrating the wins. And that leads to frustration. Staff don't see the attractiveness of what they're doing. They don't see the satisfaction of what they're doing. And so they stop doing it. We have to reinforce that behavior. So make it easy. Here's what we're trying to do. We want our patients to sit up, stand up, and work. That's it. We don't want them in bed. If they were walking when they came in, they should be walking when they're here. We want to do that frequently throughout the day. We always want to get patients up, and if they cannot do it by themselves, we use equipment. If they require manual lifting and moving, we use equipment. We do not want our caregivers to be hurt as they care for their patients. So we want safety for both the patient, we do not want them falling, and for the caregiver, we do not want them getting hurt. We want to clarify steps. So when you roll out your program, clarity, clarity, clarity. Communicate, communicate, communicate. Our consulting customers get sick of us saying this. We have 4 C's: communication, clarification, community, and consistency. And we talk of these things over and over and over again, because really all of your early mobility issues can come down to these 4 things. So what is it? Clearly identify what your program is going to entail for each person. What are my roles? What do you expect of me? Make it easy. If a patient's able to sit up over the side of the bed by themselves, you know what? You're taking vitals anyway. Let's sit them up over the side of the bed every time we take their vitals. That's at least 4 times a day that we've done that. If they can stand up and get in a chair, none of those patients should be sitting in bed for meals. Get up and into the chair for meals, even if you sit at the side of the bed. Get up and be anti-gravity. Change your position relative to gravity. That's what stimulates our body to respond and to keep our regulatory mechanisms, our homeostasis mechanisms moving. Build mobility into daily care. I'm going to share a video with you that looks at using equipment to help keep patients moving. There's no audio to this, but this just shares a couple of different ways that you can see nurses are able to get patients up safely, even patients of size, safe for them and safe for the patient. So this shows a repositioning sling to the edge of the bed. With this one, we show proning, which is very relevant for our COVID patients. We show the use of a standing bed to get a patient all the way up to standing. Even if they're on a ventilator, we can do this safely. And with it being their bed, we can do it frequently throughout the day. We have powered sit-to-stand aids, where the patient can be weight-bearing, they can be up and moving. We have ambulation harnesses, where they can stand and they can ambulate. They can do ADLs. We can take them to the sink where they can wash their own faces. All of these are examples of equipment solutions where patients can be safely mobilized appropriately to their highest level with no risk to the caregivers and no risk to the patient. And then lastly, I want to just but once your program is up and running, use your data to keep driving program success. Make sure that it is reported at your quality meetings, at your patient safety meetings. So use your mobility goals. What are the goals that we're setting on each unit? Show those to the staff, share them with the staff. Set targets, share with the staff whether their goals are being met or not. Give this information to quality, share it with patient safety and with the frontline staff. What are the reasons we're not meeting our goals? Break that down for people, re-educate people what they need to do to achieve the goals if they're not achieving them. If, for example, the reason they didn't meet the goal was pain, let's pull in pharmacy, let's get pain under control and then mobilize. Let's not let those patients stay in bed with pain. And then finally, do some lagging indicators. What's happening from admission to discharge? How many of your patients you see here in the orange? These are the patients that actually got worse from admission to discharge. Set a target and hold staff accountable to that. We want to link the squares. We want to build our community. Engage, engage, engage. Thank you all for attending today. This webinar is recorded and will be available on the website for everybody who attended today. And thank you very much. This concludes our webinar.